Welcome to Phlebotomy 101. This video is intended to briefly review key points of venipuncture and provide a demonstration of safe and reliable techniques. To begin, you will want to first collect some materials. Either chlorhexidine gluconate or alcohol prep swabs for skin prep, a needle, your tube holder, the blood tube, a tourniquet, a 2x2 gauze, and either a bandage or tape. Your first decision will be the size of needle to employ. While this can be dictated by the size of the patient's veins, generally speaking, a 23 gauge is universally acceptable for most people and a good empiric choice. Recall that in the gauge system, a higher number indicates smaller size. 3 common needle types are shown above. Each needle differs in technique slightly, and your focus before approaching the patient should be to learn the safety mechanism of the device you have chosen. It is advised to waste a needle practicing the mechanism if you are unfamiliar. This way, no surprises arise. After obtaining consent and confirming your patient identifiers, your next challenge will be finding a suitable vein. Briefly review the relevant anatomy of the antecubital fossa. While you are not limited to this site, it is generally a reliable starting point on most individuals. Appropriate distal sites may include the radial surface of the wrist, the dorsum of the hand, and the ventral forearm. Applying a tourniquet can be one of the more uncomfortable parts for your patient. You will need a tight, secure tourniquet to ensure the veins are adequately distended. The goal is to partially occlude venous return while maintaining arterial flow to achieve pooling of the blood in the extremity. The tourniquet should be applied several inches proximal to your desired site. Begin by placing the tourniquet underneath the patient's arm, stretching to the desired tension, and then wrapping around the patient's arm. By pulling tension first, you can avoid pinching the patient's skin or hair. You will then pass the tails, anchor your tension with your dominant hand, and finally tuck the tail on top. Note the hazards of an incorrectly placed tourniquet. If the bottom tail is tucked, both tails will fall over the prepped skin. Additionally, when removing your tourniquet, you will need to pull your tails towards your needle, posing an obvious safety risk. Important to maintaining sufficient tension when releasing the tourniquet is to secure your anchor just above the skin. In tucking the tail, be sure that both sides of the tails face away from your site to avoid contamination. Palpating for a vein is best done with an ungloved fingertip with gentle, repetitive pressure over the region. The desired feedback from an ideal vein is often described as bounce. Recall that veins are a compressible, tubular structure without any pulsatile quality. Ideal veins will be fairly superficial, though be cautious not to be tricked into a suboptimal cutaneous vein of smaller diameter. While these may appear tempting as they are easily visible, one should trust palpation over visualization in most circumstances. When palpating, it is important to appreciate both the site of entry and the course of the vein to understand the trajectory you will advance your needle. It may be desirable to mark your site if the vein is deep or not visible to easily identify your entry site after prep. Remember that once the skin is prepped, you should not palpate this area again before venipuncture to avoid contamination and inoculation of bacteria. Let us briefly discuss some adjunct techniques to better visualize and palpate the veins of the upper extremity. First, ensure that you have a tight, secure tourniquet. This is a common mistake that will decrease your success rate. A second tourniquet may even be applied if necessary. Additionally, use gravity to your advantage. Lowering the arm to the anatomical position for just 30 seconds will assist in venous pooling. If no veins are palpated or visualized, a blood pressure cuff may be applied to aid in venous occlusion. Apply a blood pressure cuff and inflate to 40 to 60 millimeters of mercury, but be mindful of the length of time for which this is applied. Samples such as potassium, lactate, calcium, and other electrolytes may be significantly deranged iatrogenically by excess tourniquet time and cell lysis. Finally, heat packs may be applied indirectly to the region to help divert blood flow superficially via autonomic thermoregulatory processes. Several contraindications to venipuncture should be screened for prior to any attempt at phlebotomy. While arteriovenous fistulas, arteriovenous grafts, venous access devices, and lymphedema are likely apparent when examining for a puncture site, it is still worthwhile asking, is there any reason we should avoid drawing blood on this arm? Patients who have had a radical mastectomy or other contraindication will likely advocate against the use of that arm. Once the tourniquet is properly applied and a site has been identified, you may prep the skin. It is appropriate to glove for the remainder of the procedure. Remember that friction is important for an adequate prep. Both the alcohol and the chlorhexidine must dry to properly cleanse the surface. This will also prevent worsening sting at the puncture site. With your non-dominant hand, anchor the skin distally with longitudinal traction. This will prohibit the veins from rolling. It is important not to place your fingers proximal to the needle to minimize the risk of needle stick injury. Approach the vein wielding the needle by either the wings or the body in your dominant hand, aligned with the estimated course of the vein. Forewarn the patient of the expected puncture to minimize a startle response. It may be prudent to engage your patient in a conversation as a distraction. Anxious patients should be counseled to look aside for the puncture to minimize anticipatory tension or movements. A 10 to 30 degree angle, depending on your estimated depth and course of the vein, is appropriate. The puncture should be one smooth and fairly swift movement without hesitation. Recall that the sharp pain results from the movement primarily through the dermis, and hesitation here may increase the pain experienced. If correctly placed, you will then witness a flash of blood into the body of the needle, as shown. The advantage of the butterfly needle is the ability to then let go of your needle while handling your tubes. Be mindful not to place tension on the tubing while attaching and detaching the tubes. Once all tubes have been filled, take a brief pause to plan your handling of the contaminated needle. There is no rush to remove the needle at this time, and planning your actions may minimize needle stick injuries. A commonly forgotten but important step is then to remove the tourniquet before removing the needle to minimize the venous pressure. With the gauze prepared in your non-dominant hand, grasp the needle by the body, not the wings, in a way that facilitates the engagement of your safety mechanism. Worry first about securing your sharp, and second about achieving hemostasis. You may ask the patient to then take over the pressure while you prepare a piece of tape or bandage. It is worth noting that no more than 2 attempts are generally recommended before seeking consultation from a colleague. Tubes should be inverted gently, not shaken, several times to mix the contents before sending to the lab. We will next review the one-handed safety mechanisms of the 3 commonest needle types. When utilizing the safety lock butterfly needle, as demonstrated, it is important to remove the needle by the body. This yellow piece will then slide forward to lock over top of the sharp. A one-handed technique, as shown, minimizes the risk of needle stick to the non-dominant hand, which will instead be applying pressure with the gauze. The push-button mechanism is intended to be employed before removing the needle. Be mindful that this spring may result in unexpected blood splatter, so do not have your face unnecessarily close to the site. The Eclipse needle has a folding mechanism that can again be used with just one hand by folding forward the protector with your thumb. Let's review other worthwhile notes on safety. Be mindful that the tube holder actually contains a concealed needle beneath the gray silicone sheath. To avoid resulting lab tests on the wrong patient, confirming patient's identity with 2 personal identifiers while at the bedside is essential. The specimen should never leave the room unlabeled. An important takeaway is that exposure to a needle stick injury should never be disregarded. Once the sharp has been secured and the patient bandaged, you should notify your supervising physician and refer to local protocols. That's all, and thanks for watching. We hope this demonstration helps you feel confident about your first blood draw.